Good afternoon, students. Today we are going to discuss about distribution of the drugs. Second part of the pharmacokinetics. Then distribution, it is a reversible transfer of drug between one component to the another component. That is from the blood to the extravascular tissue. If you imagine body volume is a 42 liters, that is divided into two parts. Intracellular 28 liters, extracellular 14 liters. This extracellular again divided into interstitial fluid 10 liters and plasma volume is 4 liters. Then what is the volume of distribution? Now, if you administer the drug, if it is distributed entire the body, it's called as a volume of distribution. But it will be happen. Will it be happen? No, because some drugs will have the concentration in the blood more, then less in the fluids, less in the organs. Okay, then that time we will have the new concept is called as a apparent volume of distribution. What is the apparent volume of distribution? Now, if you administer the drug, if body we imagine full is a single unit, full all over the body, if it shows the same concentration, it is called as a volume of distribution. But we have only 42 liters. Then in that 42 liters, if it is body is distributed, it's called as a volume of distribution. But some drugs will have volume of distribution above, sorry, for example, you say 400, 500,000. Then how it will possible? We don't have that many volume in the body. But we say this drug has distributed 1000 liters. How it is possible? That concept is called as a apparent volume of distribution. How we say apparent volume of distribution? Some drugs volume of distribution is more than the total body volume. It is called as a apparent volume of distribution. If drug have more than 42 liters as a distribution, it's called as a apparent volume of distribution. What is its important? Or how it will be calculated? Now I say apparent volume of distribution is calculated by total amount of the drug in the body divided by plasma concentration. Here we can see the two things. Total amount of the drug in the body is 1000. Then plasma concentration is 50. Now if we calculate volume of distribution is 20 liters. But same thing, if plasma concentration reduced to 5, this plasma volume of distribution become 200. How it is possible? Here 20, here is 200, but this has a volume of distribution, but this 200 become apparent volume of distribution. Here simple thing is, whatever drug you give or how much concentration you give, it has to distribute it within the specified amount, or it should be concentrated in that. That is called as a apparent volume of distribution. Here simple is what it has to distribute more than that in the volume it is distributing, it is called as a apparent volume of distribution. Here what is the clinical significance or significance of volume of distribution? Drugs have high volume of distribution, have drug accumulated in the body tissue. Then it should be given in the loading dose to attain the therapeutic concentration. Difficult to remove by hemodialysis. Drugs have low volume of distribution. Drugs present mainly in the blood and easy to remove by hemodialysis. If any person have the high volume of distribution and the poisonous means you have to do the, if you do hemodialysis also it not be work out. Then here we have the examples of low volume of distribution from 5 liters to 20 liters commonly using drugs. Then here we have the medium volume of distribution from 40 to 7 to 77. Then here drugs have the high volume of distribution. Here you can see the chloroquine have 13,000 as a volume of distribution. Then factors affecting the volume of distribution. These are the major factors will affect the volume of distribution. That is the lipid solubility, ionization state, plasma protein binding, affinity for different tissues, redistribution, tissue permeability. How it will be affect? If drug has high lipid solubility, it will have high volume of distribution. If drug is unionized state, it will be having high volume of distribution. Then plasma protein binding. If drug have high plasma protein binding, they will be circulated in the only blood. That's why they will have low volume of distribution. Then affinity towards the different tissue. If drug have high affinity, it will have high volume of distribution. Low affinity, low volume of distribution. Redistribution, if drug undergoing redistribution will have high volume of distribution. Then tissue permeability. If the drug is permeable to everywhere in the body, and it will have high volume of distribution. These are the major factors will affect the volume of distribution. Then what is redistribution? Redistribution is highly lipid soluble drugs stored in the tissue. When the plasma concentration of drug decreases, they release into the blood. Simple I say, when you administer the drug, it concentrated in the plasma. From plasma, it will go to the storage area. When plasma concentration is coming down from storage area, again it will come back to the plasma. That is called as a redistribution. From plasma to the body tissues is distribution. From body tissue again come back to the plasma, it's called as a redistribution. Then drugs distribute from which organ have high blood supply. First they will distribute into the high blood supply, brain, heart, kidney, followed by low blood supply but bulky muscle and tissues. Example, myocardium will have the digoxin, liver chloroquine, fat, thiopental. These are the important drugs have undergo redistribution. Then clinical significance, long duration of action, difficult to remove from the body in case of poisoning, can produce the toxicity. Next, loading dose required to achieve the desired plasma concentration. These are the clinical significance of redistribution. Then next come to the one of the important short notes question, plasma protein binding of drug. What is plasma protein binding drugs? Anna? Even if you give the drug, it will go and bind to the plasma proteins. It's called as a plasma protein binding. The process of complex formation drug which plasma proteins is called plasma protein binding. Now, how with which bond drug is binding to the plasma protein? There are two types. One is a reversible and irreversible. If drug form the hydrogen, hydrophobic, ionic, and van der Waals forces with the plasma proteins, it is a reversible. If drug is made covalent bonding, it is a irreversible. That means you cannot remove from the body. Then, what is the importance of plasma protein binding? That is a basic drugs bind to the alpha 1 acid glycoprotein, acidic drugs bind to the albumin. Then, these are the specific, non specific binding. That but we have some specific proteins to bind to the specific drugs. For example, if you see estrogen, it will bind to the globulin. Then, steroids, if you see, they will bind to the transcortin. Thyroxine will bind to the thyroglobulin. Then, antigens will bind to the alpha globulin. Like this, some have non-specific, some have the specific. Then binding depending upon the affinity, concentration of drug and number of binding site. When drug has to bind to the plasma protein, three important things: drug concentration, then how much drug have capacity, affinity towards binding, then number of binding site. These three things will decide how much drug has to bind to the plasma protein. Then it is a saturable. Once all binding sites are over, then new drug cannot be bind. That's why it is called a saturable process. Then, whenever due to the pathological conditions, this plasma protein concentration may increase or decrease. That time, free form of the drug may increase or decrease. That will affect the drug effect. Then, drug here we have the some example binding to the albumin. Then acidic drugs bind to the albumin and the albumin will have the two binding site. One site 1 or warfarin binding site, site 2 or benzodiazepine binding site. Site 1 phenytoin, then sulfonamides, then bilirubin will bind to the site 1. Then site 2 naproxen, propan acid, cloxacillin, tryptophan, benzodiazepines will bind to the site 2. Then tolbutamide, salicylic acid, glipizimide, indomethacin. These will bind either site 1 or site 2 depending upon the availability of the site. Then these are the drugs bind to the alpha 1 glycoprotein. Mipramine, bupivacaine, verapamil. Then till now we have seen the plasma protein binding. Here, some of the drugs will bind to the tissues, body fluids, bone and fat. For example, if you see the thyroid, iodine will bind. Iodine will go store in the thyroid. Then bone, calcium, phosphate, tetracycline, cisplatin. Then liver, vitamin A, chloroquine, mepecrine. Then retina, chloroquine, kidney, gentamicin, muscle, digoxin, emitin, skin and nails, gresofulvin, teeth, fluoride, then fat, thiopentone sodium, ether, minocycline, phenoxybenzamine, all these drugs will store in the fat. These are the examples of tissues, glands, then fluids, bone, all that thing example on which drugs will be concentrated, binded. Then what is the clinical significance of plasma protein binding? Here, maintain plasma concentration. Free form of drug shows the pharmacokinetic and pharmacokinetic properties. Then if drug bind to the plasma proteins, it won't do anything. It will be there inside the body. Then low volume of distribution because they will serve only in the circulation. That's why it will be they will have low volume of distribution but long duration of action and they cannot be removed by hemodialysis. That's why any person is poisonous with the high plasma protein binding drug and you cannot you do hemodialysis also there won't be any use. Then plasma protein binding replacement can increase the effect. Because if replacement law, what will happen is if you combine two drugs, one drug replace another drug means another drug concentration, free concentration will increase. That will produce a more effect. That's why whenever you are treating the person, you should ask if he has any, if he is suffering with any type of diseases which affect the plasma protein concentration. Then plasma protein binding replacement can produce toxicity for low therapeutic index drugs. For example, if you are replacing the low therapeutic index drugs on a free form of drug will increase, that will leads to the toxicity. Even if you give normal doses, this because of this plasma protein replacement reaction will produce the toxicity. Example, aspirin with the methotrexate. Next, what are the some diseases you see the increase the toxicity because of reduce the plasma protein? For example, if you see hypoalbuminemia, renal diseases, hepatic diseases, malnutrition, all these conditions you will see the decrease of plasma proteins. That's why if you give the same dose, drug toxicity will increase because free form of drug will be more. Example, phenytoin, diazepam, theophylline, warfarin. These are the drugs you should be while giving to the renal disease, hepatic disease patient. You should reduce the dose because plasma protein concentration will be reduced. Then, acute MI, rheumatoid arthritis, carcinoma, Crohn's diseases, they will increase the alpha glycoprotein levels. That's why therapeutic effect will be reduced because if you give the same normal dose in these conditions, the drug will go and bind to the alpha 1 glycoprotein. That's why free form of drug will be available less. That's why you will see the effect will be less. That now we are going to discuss with the individual drug in normal condition and disease condition and how it will be changed. For example, if you see diazepam in normal person 2%, but in hepatic disease that concentration becomes 6 times, means 3 times more. That's why you will see the toxicity. Like said theophylline 35%, but in the hepatic disease like that concentration will increase, free form of drug will increase to 70%. Then it will lead to the severe toxicity. Like that we see the renal diseases, furosemide normal 2%, but six times that, 3 times effect will be increased. That is clofebrate, phenytoin, trimethoprim. But this increase, if high therapeutic index drugs, no problem. But drugs have low therapeutic index like phenytoin, theophylline, they will have the severe toxicity. Then drugs with low plasma protein binding. Here these are the drugs will have low percentage of plasma protein binding. Then here drugs with zero plasma protein binding means these drugs will not bind to the plasma protein like isoprobane mononitrate, lithium, pregabalin, then isoniazid. These are the drugs will not bind to the plasma protein. That is related to the distribution. But in this distribution law, three important things you should remember. One is the volume of distribution, then factors affecting volume of distribution, redistribution, plasma protein binding is the very important short notes questions, and plasma protein binding is the very important. If you like my videos, please subscribe my channel and share your with the friends. Thank you.